Hello, and thank you for joining us today for our virtual panel discussion. We're really excited to have you here with us. This virtual panel discussion is being hosted by Action Hepatitis Canada and by CanHepC. I should say my name is Jennifer Van Genup, and I am the coordinator for Action Hepatitis Canada. And in a moment, I'm going to turn it over to Sophia Bartlett. She is a steering committee member with Action Hepatitis Canada, and she is going to do a land acknowledgement. And then when Sophia is done, then we have a pre-recorded greeting actually from Ms. Bursable Ephraim. She's the Director General for the Center for Communicable Disease and Infection Control with Public Health Agency of Canada. And so we were grateful to have her provide a few opening remarks for our event today. So I will turn it over to Sophia. Thank you.
I would like to begin by acknowledging that we're fortunate to be able to come together today virtually for this discussion, but that we are all on the unceded territory of the First Nations peoples of what is sometimes referred to as Canada. I'm joining today from the unceded territory of the Coast Salish peoples, including the Musqueam, Squamish and Tsleil-Waututh nations.
Good afternoon, everyone. Bon après-midi à tous. First, I would like to acknowledge that I'm speaking to you today from Ottawa-Gatineau, which is a traditional unceded territory of the Algonquin people. My name is Bursable Ephraim. I am the Director General for Communicable Diseases and Infection Control. Je tiens d'abord à remercier Action Hepatitis Canada de m'avoir invité à offrir un mot d'ouverture dans le cadre de la table ronde virtuelle d'aujourd'hui sur le traitement de l'hépatite C au Canada. Thank you for inviting me to speak to you today. As the estimates from the Public Health Agency of Canada released last week indicate, by the end of 2017, it is estimated people with the infection. Of these, it is estimated that nearly 200,000 people in Canada were living with chronic hepatitis C infection. Canadian studies have shown that only 70 to 85% of those who test positive to hepatitis C will go on to get tested for chronic hepatitis C infection. And we know that this diagnosis is key to getting access to highly curative, effective treatment that are currently available. In the Government of Canada 5-year action plan on sexually transmitted and bloodborne infections, which was launched last year, the government committed to reducing the incidence of sexually transmitted and bloodborne infection, including hepatitis C, by working with partners and stakeholders. It intends on doing so by improving access to testing, treatment, care, and support. And it's also by reducing the stigma and discrimination that undermine access to effective prevention, testing, treatment, and support. Yesterday, the Public Health Agency of Canada launched the solicitation for the HIV and Hepatitis C Community Action Fund and the Harm Reduction Fund. Both funds support community organizations doing important work trying to reach the undiagnosed among our key populations, including people who inject drugs who are the most impacted by hepatitis C in Canada. De plus, depuis 1999, l'Agence collabore avec les instituts de recherche en santé du Canada sur l'initiative de recherche sur l'hépatite C. Cette initiative appuie la recherche et le renforcement des capacités dans le domaine de l'hépatite C, créant ainsi un continuum de la découverte à la mise en œuvre. I cannot conclude my remarks without noting that COVID-19 has disrupted all of our lives in so many different ways. The pandemic has created an even more difficult environment for populations impacted by hepatitis C to access key services such as harm reduction and prevention, testing, and treatment. It also makes it much more challenging for the community-based organizations to reach those in our communities who need the most support. So I want to thank you for all your efforts in trying to find innovative solutions to reach communities during these difficult times. You're truly inspirational. I wish you a productive panel discussion on what it would take to bring same-day HCV treatment starts in Canada. Merci et je vous souhaite une discussion productive sur ce qu'il faudrait faire pour que le traitement de l'hépatite C commence le jour même du diagnostic au Canada. Thank you.
Thanks, Bersabel, for that welcome and introduction. So to start off with, I think it's good to think about the fact that there was a brief moment when Canada was on track to achieve the elimination of hepatitis C virus as a public health threat by 2030. But unfortunately, that was a fleeting moment, and the goal is now looking increasingly out of reach. And on top of that, the COVID-19 pandemic has interrupted healthcare even further over the last 8 months. And hepatitis C treatment uptake numbers will need to increase substantially in 2021 to get Canada back on the elimination bus. Rapid or same-day hepatitis C diagnosis and treatment starts have been proposed as a strategy to assist in increasing treatment uptake in Canada, as there are indications in other settings that this model can increase the proportion of people who progress along the care cascade to treatment. But with 13 different territorial and provincial healthcare systems, plus 3 additional federally funded programs for people with First Nation status, people who are federally incarcerated, and veterans, it's difficult to know where to start to begin implementing a policy like rapid or same-day diagnosis and treatment starts for hepatitis C. So Action Hepatitis Canada has conducted an environmental scan of the hepatitis C treatment reimbursement approval policies across Canada, focusing on 5 key areas that have been identified as being related to being able to do a same-day diagnosis and treatment initiation for hepatitis C. So you can see the results of this environmental scan here, and we've colour-coded the policies that are in place in each jurisdiction in these 5 key areas. Green means good. This means there's no barrier to same-day treatment starts with the policy that's in place in this province. Orange means okay. Functionally, this policy doesn't create a barrier, but there's a possibility that it could become a barrier at some point. And red means, predictably, that this policy is a barrier to rapid or same-day hepatitis C diagnosis and treatment starts. If all the boxes are green along a row, then this jurisdiction doesn't have any barriers right now to rapid or same-day hep C diagnosis and treatment start. So Prince Edward Island, or PEI, is the only jurisdiction right now that's all green across the row. Quebec is close, but because no province or territory has access to rapid hep C RNA point of care tests that are approved by Health Canada, PEI has an exemption here, then we're all going to fall short on this target. We're really fortunate to have Professor Jason Grabley and Associate Professor Curtis Cooper joining us today. So I'm going to ask Jason and Curtis, based off what's happening in Australia and other countries that are on track for hepatitis C elimination right now, can you look into your crystal balls and tell us what you think could be the impact of rapid or same-day hepatitis C diagnosis and treatment starts in Canada? And how do we get there? Jason, maybe you'd like to start us off and share some of your initial thoughts.
Hello, everybody. Great to be with you guys today. So I think we got to take one step back, I think, and really sort of understand, where the potential lies. And really the barrier here is that sort of conventional testing is a 2-step pathway. So we end up having to do an antibody test first to detect exposure. And this is generally because it's a lower price test. And then we have to do RNA testing to confirm active infection. And the result is that this ends up being, could be up to sort of a 6 or 7 visit process by the time particularly if you have to go off-site for phlebotomy. I think that it's really exciting, the availability of a point of care RNA test, because it really truly brings us closer to a single visit diagnosis. In Australia, I guess I want to cover things in two sections. First, describe a little bit about the Australia DAA program, then discuss a little bit about some of the work that we've been doing, and then lastly, just about barriers to point of care RNA testing that we're also facing in Australia. I've been quite immersed in this over the past several months, working with the Commonwealth government around this. So just some features of the DAA program that are important if you look back and if you consider Sophia's the really nice chart that she's put together. So I think the first thing to note is that DAA reimbursement is quite different in Australia compared to Canada. And as many people know on the call, I'm actually Canadian, but I've been living in Australia for about 13 years. The first thing is that the program is a national program, so it's not dependent on the states or territories here in Australia. So what that means is, and the government took a very public health approach to DAA therapy. So essentially the therapy is funded by the federal government. There's a cap on expenditure each year, but there's no cap on the number of people that can be treated in a given year. So, and the restrictions around therapy were incredibly broad. So there was no restrictions based on disease stage, no restrictions based on provider type, and no restrictions based on recent drug or alcohol use. So I think those are the key sort of features which really enable, provide a bit of a platform for single visit testing and treatment. The other thing that to note is that the approval process going to sort of, so I've ticked off two things, well, mainly the fibrosis. In terms of the Hep C RNA testing, there's no need to show any RNA tests. The indication is for chronic infection, but there's no need to actually show to the government that there's a certain number of Hep C RNA tests that have been done. So that takes away that barrier. And in terms of the DAA approval time, what happens is that actually a clinician phones up the pharmaceutical benefits scheme, provides information on the fibrosis status, and previously had to provide information about genotype, and I'll get to that in 1 second. It's a phone call. Essentially, the approval happens immediately, and the participant can take their script or the physician can write the script, the patient can take the script to the community pharmacy, and the script is filled. Genotype was a barrier until recently, so the government has just made changes through sort of a consultation process with a number of sort of national organizations, and so genotype is now no longer required for prescription of hepatitis C therapies. So I think now we have the processes in place. The bit that still hasn't been addressed is the barriers around sort of point of care RNA testing. We've done some pilot studies. We've got about 38 machines sort of across sites in drug treatment clinics, needle syringe programs, reception prisons, tertiary care hospitals. And we've actually got a couple of sites in Canada as well. But these are all through research projects. And what we have is a waiver through the government to use the test for research purposes. Now, that was up until earlier this year. And now we've received approval from the Therapeutic Goods Administration to be able to use the assay. And there's a couple of conditions. The assay needs to be either performed by an accredited lab, or it needs to be performed by a site that has a relationship with an accredited lab. There needs to be a quality assurance and quality control system in place for the monitoring of the testing. And then there needs to be operator training programs in place. So these are all obligations that the company needs to sort of adhere to. The other thing that's important to note is that is Therapeutic Good Administration approval. That's not actually reimbursement of the test. So we're just going through another process now where we're going to be probably applying for a revision to the existing item codes for Hep C testing. Again, Hep C testing is funded nationally, making it a little bit easier. But the key issue right now is that an antibody test needs to be done before an RNA test can be done. So, and that's to prevent obviously people from using RNA as a first line in low prevalence populations. So we need to address that. And the other thing is this issue about needing to be done by an accredited lab. So we may need to create a system whereby there's an item number for particular sites in order to get reimbursement for the test. I think I'll stop there because I think that provides enough context. The one thing I just wanted to say is the potential is enormous. We have, in terms of some of the pilot studies that we've been running, we've got some data starting to emerge at needle and syringe program, and also at a reception prison that we've been working on. And we had a period of standard of care, and then we had a period of intervention. And in the prison project, the standard of care treatment uptake was about 26%. And with the single visit sort of one-stop shop with FibroScan based disease staging and then fingerstick point of care, treatment uptake has been about 96%. And we've seen about a 90% treatment uptake in our NSP program as well. So I think it definitely will remove those barriers, and it's quite an exciting new technology. So now it's just a matter of us coming up with situations, and in Canada, I think we need to get angry. We need to be advocating for ways that we might be able to remove some of the barriers that Sophia have highlighted, because I think they're just getting in the way of providing more accessible testing and treatment for people. So I'll hand it on to Curtis, because I think it'd be really great to hear from him, or I'll hand it back to Sophia so that she can kind of chair things. But thanks so much, and happy to answer any questions later on.
Thanks, Jason. I think we'll just go straight over to Curtis to sort of, maybe you might be speculating a little bit, Curtis, but maybe just to sort of touch on maybe specifically what you think the applicability of model of care like this in Canada would be. Would it be for specific groups of people, or maybe also thinking about if we wanted to have the best bang for our buck, where would we align across all of the provincial kind of governments and territorial governments to try and pick one area that we move forward on in terms of the policy landscape to try and get this same day treatment starts in Canada?
Sure. Well, I will give it a stab. I think everybody on the panel and in the audience understands that this is a very complex situation. As we're all aware, in Canada, we have multiple provinces and territories and other jurisdictions that all have different rules. And what might work in one area or what might be needed in one area maybe isn't what is needed somewhere else. So I come at this as an infectious disease specialist. I've been providing care and conducting research in the area of hepatitis C for 20 years. I guess by nature, I come to, my approach to providing care for hepatitis C is let's get this done and let's get the person cured. Historically, so you look at the table that's been constructed, and I mean, this is a patchwork of obstruction. And, just to sit back for a moment and say, well, why are we here? How did this ever happen? Because if hepatitis C had, just magically appeared today, along with direct acting antivirals, I'm pretty sure this isn't what we would construct as far as a cascade of care for individuals. I think part of this is still a residual hangover from the days of interferon, when we were, with good reason, very, very cautious in every single person that we encountered to make sure that they really needed the treatment and that it could be safely delivered, just because of all the side effects. And it was also expensive, and so there was, at a payer level, a reluctance to provide the coverage. And in the old days, we, for any dose of interferon that you wanted to order, there were all sorts of forms you'd need to complete and go back and forth to the province. So this is this residual hangover that we're still struggling with, even though we've advanced to a point where these medications are as simple as a vitamin C tablet to take for most people. They're very safe, they're very well tolerated. This layer of caution is excessive, and it's actually not helping on a public health level as far as reducing the burden of hepatitis C in our country. And on an individual basis, it's not helping. We want to get these excellent treatments to the people who need them. So let's acknowledge the good things. One really good thing in Canada is that eventually the medications will be paid for everybody in almost every jurisdiction. I'm sure somebody can find an exception to that statement, but by and large, if I have a patient in front of me in my Ottawa-based clinic, I know that eventually I'm going to get them on therapy. Okay. And in many cases, we do get those patients on therapy same day. So it is possible in Ontario to do that with some people that we see. So if they're on Ontario Works, if they're over 65, if they're under 24, those folks can get on therapy same day, which is great. It's an opportunity when a person is sitting there in front of you. Now's the time to strike and get things going. For a lot of our clients, if they've had for a whole lifetime of guys that look like me telling them, no, we can't do it today. Sorry, come back next time. And so when somebody's sitting there and I say, sorry, can't do it, we have this and this and this to do, I think the message they're receiving is, I don't want to treat you. And it's not the message we want to convey, but that's the message that's received. So I think as far as tackling this issue, there's the what do we do on a Canadian-wide basis, and then what do we do in our own clinic to try and move things along so that we get more of these boxes in the green area. And I guess to me, I think we need to look at the examples for where this is working, either in Canada or elsewhere, and instead of trying to tackle this whole thing, which is overwhelming to even think about, you say, okay, well, where are the priorities? Well, point of care testing, that's a priority. We have to have this. We look for the now mass of data worldwide that has been presented year after year at the major liver meetings. And I know many people on the call here today have a lot of experience using these point of care tests. They're easy to do. People like them. And we have to sort of collect this data. I see this perhaps as a role of the Canadian Hepatitis C network. And we take this to each province and we say, this is the data, these are the problems that not having this test is causing. In the case of genotyping, I think anybody who does any hepatitis C treatment at all recognizes we don't need this test. There's no reason why this should cause a second of delay in proceeding towards therapy. So in Alberta, they've said, okay, we're not going to run genotypes anymore. We're not going to make this part of the necessary information you need to approve or fund treatment. And we take this is working. It's not causing any problems. It's facilitating care. You take that example, organizations like AHC, organizations like CanHepC, we put this together and we go to the provinces and we say, look, this is something that we can easily address. You look at the process for approval, and I would argue that why in this day and age do we need approval to start therapy that is so clearly safe, so clearly effective, and that we can use in everybody. There's boatloads of clinical trial data, and there's boatloads of real world data that tells us about the safety and efficacy. And all this does is it delays treatment, increases the risk of loss to follow-up, people getting frustrated and saying, well, they're not serious about treating my hepatitis C. So look at the Ontario example. Look at the data. There was just data presented at AASLD a couple of weeks ago, which tell us that in people who start therapy same day, they do just as well as far as completing their therapy. I think one thing we could do is add to that body of literature, which would be to demonstrate that if people start therapy same day, their likelihood of a cure is just the same as waiting for or delaying the initiation of therapy. Now, just before I wrap up, I just want to remind everybody that everybody who's being assessed for in clinic for hepatitis C treatment is a little bit different. So in some cases, it makes all the sense in the world to say, all right, we know you have chronic infection. We don't think there's any really big complicating factors about your case. You're keen to start on therapy. Let's do it today. There's other situations where we want to prepare the patient to maximize your likelihood of success on these treatments. And that might mean trying to integrate a little bit more mental health support, a little bit more support with the recreational drugs, make sure that we've done a thorough drug-drug interaction study. So we're all keen. I know you guys are keen out there to start people. I'm keen to start people right then and there. But we want to really make sure that everybody gets the workup and the attention that they need. And in some cases, that might mean delaying the therapy a couple of weeks while we get them in a best possible position to complete their therapy and best chance for a cure.
Yeah, the point isn't, right, to have a one size fits all, everybody's going to start treatment on the same day. The point is, how do we remove restrictive policies which frankly don't make sense so that physicians and people treating hepatitis C can tailor treatment to the person and offer them what they need, whether it's a same day treatment start or something else. Jason.
Yeah, so I just wanted to say, and going back to Samir, that's great, Curtis, and I agree with everything that Curtis has said. And I should have noted that in some of the stuff we've done, actually about 2/3 of people started on the same day, and you get people that, you know, start in that post period and you're getting them prepared. So I totally agree with Curtis about an individual approach. Just going back to your question, to one of your questions, so about sort of where best to implement different strategies. I think the other thing to note is that, you know, finger stick point of care RNA testing is one tool in our toolkit in terms of the RNA component. You know, I think point of care antibody testing, but also dry blood spot testing are two other sort of tools in our toolkit. And I think really it's key to understand where to best implement different treatment strategies. And it's going to depend on a couple of things. It's going to depend on the prevalence of Hep C in the population. It's going to depend on the price of the test that you're using. And it's also going to be determined based on the proportion of people that you're able to link into treatment and link into care. And so, you know, in a low prevalence setting, so for population-based, if the prevalence is 1%, it would be crazy to go straight in with a finger stick point of care RNA test. It just, I don't even need to do the cost effectiveness analysis. It just wouldn't make sense. So that's in a situation that you might go in with a point of care rapid antibody test first as a pre-screen. And then in those that are antibody positive, you then might go and do a reflex point of care RNA test to determine active infection. And then you need to think about, and then dry blood spot testing might be another sort of tool. So where might finger stick point of care RNA testing be useful? Well, needle syringe programs, places where you're going to have a higher prevalence of hepatitis C and where you get a big benefit in getting people more rapidly initiated onto treatment. So needle syringe programs, drug treatment clinics, community health centers with a high burden of people who inject drugs, and prisons. I think prisons are key, and particularly reception prisons, the ability to sort of engage people. Now, I know in Canada it's a bit more complex at prisons versus long-term stay and how long you're going to be in for. So there's all sorts of issues, but particularly in settings where there's high transitioning, if you can sort of engage people, particularly with an 8 or 12 week duration of therapy, it makes sense. And I just want to try blood spot testing. We need to look at that more as well. That I think in prisons, it's been really successful in New South Wales, being able to do testing out in the wings without having to pay a guard to bring somebody to the clinic. And then, there's lots of resources. So that's, and then the last thing I just want to touch on is the point that Curtis made about, I think it's really important, his point about going to the provinces. And I think it's really thinking about what arguments you're going to take. And we are trying to do some health economics analysis and look at the cost effectiveness of different testing strategies. And the question is it cost savings? I think in the genotype component, and I think Curtis probably, you make the argument that this actually saves money. By removing the genotyping, you're saving 100 and whatever dollars it is doing that genotyping. So why are you doing that? And then, and so that's key. And then on the point of care side, we still need to look at the cost effectiveness, but it does definitely reduce the number of visits. So there's surely some cost saving there, but we still need to do, like I think what Curtis said, it's really important that we get more data to ensure that these single visit starts, that people are doing as well, and that they are maintaining cure, because we can't compromise on that. So I'll just leave it there, but yeah, thanks, Curtis. I don't know if you have any further comments.
Yeah, well, no, thanks for that. And I mean, it takes a combination of things, right? It takes the data. It also takes a common, if it makes sense and it's common sense, that helps to sort of carry the message. So I mean, the example that I'll return to is the need for to fax in a form to get approval to use the medications, and that can take anywhere between a couple of days to weeks to months. Maybe that made sense when we first had DAAs, and there was a concern amongst payers that, oh my God, we're going to be paying for 100,000 courses of treatment in the first 6 months, so we better just try to have a mechanism to control the amount of prescriptions that are being approved. We know that hasn't happened. I mean, we're doing good, but we're not going to treat all 350,000 people in Canada in the next 6 months if all those boxes go to green. And so with that experience, we can go back and say, look, you're not going to blow the bank. The costs aren't going to be excessive. And also remind them that we do have a commitment to the World Health Organization, that we want to treat as many people as possible so that we can hit our targets, which our federal government signed on to, and that we're all deeply committed to trying to assist. So it's that combination of a passionate argument that makes sense with some data to show that we're not going to blow the bank, and as Jason said, by using these point of care tests, we're not going to do them irresponsibly or create excess false positives or false negatives concerns.
Thanks, Curtis and Jason. So we're going to just move on now to our community panelists, and then we'll come back to all of the questions at the end.
Thanks, Sophia. My name is Leslie Gallagher, and I am moderating today from Saskatoon, Saskatchewan. I am going to introduce to you 4 panelists from communities in 3 provinces and 1 territory within Canada. They have been invited to present their observations from the perspectives of individuals living with Hep C. Moving policy to streamline Hep C treatment is important, and there's many reasons for this, certainly not least declaring that there's an urgency to treat Hep C and making sure that healthcare providers and patients are aware of this, which seems to be somewhat lacking. But certainly policy is not the only challenge facing Hep C treatment delivery in this country. So I would like to introduce Louis Joseph, also known by Luigi, from Montreal, Quebec. He's a project officer from CanHepC, which translates to Hepatitis C Multi-Purpose Associative Center. It's a nonprofit in Montreal, the leading resource in Quebec for hepatitis C and co-infection with HIV and hepatitis C. So Luigi, I've noted looking at the graph that was posted earlier that Quebec is actually quite liberal in a lot of these policies, second only to PEI. So I'm wondering if you have noticed a change in delivery of Hep C treatment in Quebec because of these changes in their policy. And also, we'd probably all like to know, we know that Quebec has had extremely high rates of COVID-19, as well as we've all suffered, but I know that Quebec has certainly recently had an issue there. So we'd like to hear your thoughts.
So hi everyone. So you can probably notice that or guess that English isn't my first language. So Leslie already presented CAPAC and myself. So just to add that we're working on about hepatitis C and STBBI since 2003 in Quebec and based in the unceded territory of so-called Montreal. So yeah, the first big advancement about hepatitis C that is recent and is like you said, we can see in the graph that Quebec is doing well, but a recent advancement was at the start of 2020. So in Quebec, Hep C treatments are categorized by the health insurance as exception treatment, which meant before that doctors had to fill a form and send it to the provincial health insurance or RAMQ and wait for their agreement. So it usually took 2 to 3 weeks. And it was one of her key advocacy to demand that Hep C treatments be removed from the exception treatments list by the RAMQ, so it can start, so the treatments can start sooner. But last year, we learned that long-awaited work in the RAMQ and Health Ministry on their informatic systems came to fruition. So with the new system, Hep C treatments don't have to be taken out of the exemption list, since now the doctors can fill the form and have an answer in a couple minutes. So so that's a step forward. Another progress with the cascade of care was last month, when the government did an update of the guide for healthcare professionals about care and treatments of hepatitis C. So in this guide, they didn't mention same-day diagnosis and treatment, but they suggested the use of biochemic scores through APRI or FIB4 instead of FibroScan. They also suggested the general use of pan-genotypic treatments. Some specialized Hep C practitioners here do the same-day diagnosis and treatment, but it is still kind of marginal. But still, we consider this recent update of Hep C treatment a good step towards faster cascade of care, since those points were also key advocacy demands for us in the last couple of years. And then what remains to be done? So our main focus since 2 years is about testings. So here in Quebec, community or social workers aren't allowed to practice testings, even with ORAQUIC. So we're advocating for a law and rule change so that community and social workers could get formation on how to use ORAQUIC and then could practice this point of care medical act. We're also advocating, like Jason mentioned, for other testing technologies by the public sector. So of course, RNA reflex testing, but also dry blood testing for very remote regions like in the north. So also for the COVID part, like you mentioned, Leslie, where there is a situation because most specialized STBBIs or harm reduction nurses were mobilized for COVID, and testing has stopped in most cases. So we are working with other groups and coalitions on that issue. And to finish, we also have in our advocacy list for the government a couple other things we're working on and prioritizing is, so the first one is to expand the HCV practice to clinical nurses through the use of collective ordinance. We also had issues in the recent years with public health data and are asking for more transparency, accountability, and reliability in epistemological data. And at last, but not the least, you won't be surprised that one of our main goals is for the recognition of the leading role of community groups, especially in the cascade of care through support of marginalized persons, and to have adequate and stable funding. Merci beaucoup tout le monde.
Thanks, Luigi. So the next panelist that we have today is Jennifer Broad. She comes to us from the inner city of Toronto. She works as a member of hepatitis C teams for more than one clinic there. Jennifer, really interested to hear, working closely with Hep C patients, really interested to hear what your observations have been, certainly within the last year. Also, I think it's noteworthy that Ontario is the only province that's demanding 2 RNAs 6 months apart for proof of chronicity. And I wonder if you're finding that impactful. Having said that, we're all in Canada supposed to be treating patients with chronic hepatitis C, which is another discussion about why we're not addressing patients living with acute Hep C, but that's another story. So please, Jennifer, let's hear your observations.
Thank you very much, Leslie. Yeah, so I work with the Toronto Community Hep C program. I'm a community health worker here, and we provide Hep C diagnosis and treatment to anyone who comes in, but our main focus of people that we want to see are marginalized communities, prison population, the homeless population, and of course people who use drugs. And so in thinking about this, the fact of the matter is treatment is pretty simple now, right? So it's not a lot of side effects. It's certainly not like it was back in the day of interferon. But that being said, our clients aren't simple, right? They're very complex and they have a lot of things going on. And particularly right now, with the overdose crisis here, it's not, just here in Ontario, but I think most of our provinces are dealing with an overdose crisis. And then with the COVID, things are become really difficult for our clients. And I would say, one of the things I think, that's really become important in getting people to treatment is, and it's always been this way, is building those relationships and building trust with clients, and then being able to deliver client-centered, client-driven care. So having said that, when a client comes to us, they come in and they're like, oh, I want to be tested for Hep C. Can you test me for Hep C? And there is problems in that we oftentimes, as Jason spoke to earlier, we're not able to actually give a diagnosis immediately in that moment because we don't do HCV, POC, RNA testing. And I really think that that's a miss for us here in my area. I think even if even if we can actually let someone know that they definitively have hepatitis C, I think there's a huge value in that. And that value is twofold. So it, you know, can also get the person to thinking about like, oh, getting to treatment, but it also is a way in which we can provide an answer to somebody in that moment and not have to tell them, oh, you need to come back later. Oh, we need to do this. Oh, we need to do that. So we can actually give them a definitive answer. And it may absolutely impact their behaviors outside of, in what they do. And so that it may actually give them reason to develop stronger harm reduction practices. And the other thing that I would say is, like, we do have to develop relationships with people. And I think, one of the first things, and maybe one of the best ways in which we can begin to do that and developing trust in those relationships is to actually be able to say yes. To say yes to our clients. So to say yes. Yes, you have Hep C. Yes, I can treat you. No, I don't have to wait for 6 months. As to what Curtis had said earlier, he did mention that, we have done some things well. And so, one of the things that we did very well was moving the fibrosis, removing the fibrosis scoring and the needing the fibrosis scores for and needing to be like a 2 out of 4 before we could even do treatment. And we saw a huge uptake in people getting onto treatment when that requirement was removed. The 6-month chronicity is also another huge requirement. Understand that a lot of times when our clients come to us, and in that moment and in that time, they're thinking about their Hep C, they're thinking about possibly wanting to get treated. But that window sometimes is very small. And, again, as to, what Curtis said, if I have to tell them, no, sorry, you have to come back in 6 months, all they hear is like, oh, another person telling me no, another person saying I can't, no one wants to help me. And that's very detrimental to our clients, right? It's very detrimental. I mean, it's not the way that we want to start building the trust and building those relationships. So I would say that I think it becomes really imperative for us to be able to say yes and to be able to provide the treatment for people. And not have to do 6-month chronicity. And the bottom line is that, if we remove the 6-month chronicity issue, we're not putting other people at risk if we treat people, so what's happening in that 6 months. And then that's assuming that a client will come back to us in 6 months. Right. But, things will happen in those 6 months. Like I said, we're dealing with COVID, we're dealing with the overdose crisis, we're dealing, with people's mental health issues. And like, life is hard. Life is hard for our clients. Who's to say where they're going to be in 6 months? Sometimes we get lucky and they come back, but more often than not, we don't see them for a year and a half, 2 years. So, one has to ask themselves, what are those clients doing and how are their harm reduction practices? And, and already we're seeing that, like, people's harm reduction practices are not as great right now, particularly during this overdose crisis. And people are willing to take chances that they haven't been doing so much of in the past. We're seeing an increase in people doing other people's washes because, they're sick and because they just don't see Hep C as being a big problem. And, in light of the overdose crisis, who really cares? Because I could be dead tomorrow from a poison drug supply. Yes, Ontario has done some things really well. I think, if we could have the, POC RNA testing and we could have the, get rid of the 6-month chronicity, I think, then we can actually, we can do that, which is simple, which is to treat people. but also it really helps to strengthen and develop our relationships with people so that we can also then work on some of the other things that are our priorities in people's lives. But I mean, the thing is, you know, we should, if someone's coming into us and they're seeing us and it's like, I want Hep C, I want to know if I have Hep C and I want to get treated, then, excuse me, we should be able to provide that in that moment. And yeah, and I think that's all I have to say.
Thanks, Jennifer, for bringing the realities to us. I think that the impact of being able to tell an individual that they're approved for treatment, that the medications are ready, and then letting them have a say in when they're going to start it, I think that having that ability would go a long way. I'd now like to introduce, we're going to jump up to the Yukon territories to Bronte Renwick Shields, who is the Executive Director of Blood Ties 4 Directions in the Yukon. When you talk about rural and remote, and you're thinking about the Yukon, the challenges of visiting specialists and shipping blood samples to provinces that are maybe not the same province that you're getting your specialist coming up from, and some of the challenges. So we'd like to hear, Bronte, what you're dealing with up in the Yukon.
Thanks, Leslie. Yes, I work at Blood Ties 4 Direction Center. We're a harm reduction organization situated on Tong, Quechan, and Kwanlin Dun territories, known as Whitehorse. And we serve the entire territory as well. We're the only harm reduction organization up here. So we do a lot of Hep C support and HIV support, which is really where our roots are. And yeah, we have some unique challenges, as you said, Leslie, in regards to remote and rural communities. We have many communities that are very small and quite a ways from Whitehorse, including one fly-in only community. And we have a specialist that only comes up every 2 months, and they're the only one that can prescribe treatment. So that does present especially a challenge for the clients that I work with, which tend to be experiencing homelessness, vulnerable in other ways, and really have a hard time making like an appointment that comes up every 2 months. So when you're not able to access treatment unless you make that 2-month appointment, if you're coming, we know that when our clients come in to say, you know what, I'm ready to get tested for Hep C, because that's a huge step in and of itself. Seeing the chance that they're going to come back in 2 months to see a specialist, we lose a lot of folks in that time span, and we know that. And we also know that, similar to a lot of what Jennifer was saying, we're dealing with an overdose crisis. It's hit the Yukon very hard. We're also dealing with people who have, no housing, mental health needs. Hep C might not be their priority right now, but if we can solve that one health issue for them and get them on board with treatment, then we're addressing that need. And as many people have said, it doesn't need to be as complicated for many of those folks as it currently is. And having access to same-day treatment, and also we don't have any point of care testing in the Yukon. So being able to give people answers sooner, being able to, as you said, Jennifer, tell people yes. We're telling people no a lot, and a lot of it is confusing. For example, this hasn't been officially said, but we know from many of our clients' experiences that stable housing is a requirement for them to access treatment, and we have pretty much no housing stock in Whitehorse. So we have many people that want to be on treatment, have gone and met with a specialist many times, have known that they've had chronic hepatitis for a long time, and just can't get the stable housing requirement in order to access that treatment. So there's just barriers where, this person could be supported. They're accessing methadone, for example, regularly. There's ways of breaking down these barriers and getting people access to what they need. And then when we also talk about the rural communities that you spoke to, Leslie, we have people who are having to travel very large distances to get into Whitehorse in order to meet with the specialists, and the chance of them having to come in from maybe a 6-hour drive or a flight, that's a cost, and it's potentially a day where they can't work, or they need childcare, or whatever it is, and people have to prioritize these things in their lives, especially if they're already struggling with so many other things. So I really do think that the more barriers we can break down when it comes to testing and treatment, the more successes we're going to have here. And I can't remember if it was, I think it was Jason who also spoke to incarceration, and that's a huge thing we see up here. Is one of the ways actually that we are able to get some of our unhoused folks treatment is when they're incarcerated, but we have really long remand rates, and people aren't able to access treatment when they're on remand, only once they're sentenced. And that really becomes a barrier, because someone can be on remand for a year and then be released with time served. And that whole time they could have had access to treatment, but because they weren't sentenced, they weren't, and then they're released into homelessness and once again cannot access treatment. So there's just kind of these easy, as I think Sophia was saying, and many people have said, these easy to remove barriers where we can see these gaps where we could be getting people access to treatment, and we just need to take up those policies that prevent those things from happening. It's not going to work for everybody, but it can remove those, especially for people who are ready for treatment and do have the supports necessary. I think that's me.
Thanks, Bronte. I'm just thinking about a point of care RNA test for the Yukon would certainly be appropriate. So now I'd like to introduce our final panelist. This is Ray Sandini, and she is from Shining Mountains Living Community Services, based in Red Deer, Alberta. And we know that the prescriber base in Alberta has recently broadened quite a bit. So I'm wondering if that is having any impact in your community. Ray?
I hate to say it, but right now we've been so focused on COVID-19 and trying to keep people safe that at least with us, it hasn't. I'm hoping that it will. We started, I guess it would be last year, doing dry blood spot testing within our Métis population. And it was amazingly successful that they would come and see us. We did a session in Edmonton at a health clinic that was being put on with Métis Nation of Alberta. And the gentleman who'd been arranging it had asked us to do dry blood spot, and had also asked Alberta Health Services to do the same thing virtually. And he had us situated right beside each other in our rooms were located right beside each other. And the only people who would go to Alberta Health Services for point of care testing and for the test that they could provide and give them a quicker result was when we had a young lady who said yes, she could be pregnant, and we took her to Alberta Health Services and said, like, if there is a chance, you need to have your results sooner rather than later. And so over the course of the afternoon, we had 27 people come in for dry blood spot testing. Alberta Health Services had 4 people go in for their testing. And when our young lady that was doing the research and evaluation, she taught them about why they made those choices. Well, one of the things coming to us was we were all Indigenous people doing the testing. And so we talked before we, can I have your finger and take your blood now? And so we checked to see, how are you doing? How are your mom and dad? Are you here by yourself? Did you bring your auntie? And the kind of discussions that we have with our community on anything, right? That so we were really pleased with the number of people that came. And at the moment, we're still on hold. Alberta Health Services didn't have their infrastructure set up to accommodate the influx of people coming in for dry blood spot. And so we've had to create a pathway with them to be able to do that. But they've been working with us really well. And as everybody knows, with COVID-19, it sort of sidetracked everything. And I'm hoping that when we get this a little more settled out, we'll be able to go back to providing dry blood spot testing with our communities. Because like Bronte's, if they come in and say, I want to have this test, we need to be able to do it now. Not all of our people are ready. They want to have the test. They're not ready, some of them, many of them, to get the result immediately. And they want somebody to talk to when they are going to get that test back. And if they've just popped in, often they don't have supports ready. And we've lost people because of that. And yes, the getting them to specialists is a pain in my neck, because they have to go to Edmonton or Calgary. So we've been working with a research project called Drum and Sash to create wraparound services that are available to our clients, so they don't have to do that. Stan Houston is on board with us, and he's absolutely marvelous. We love having him on board, and providing us with support.
Thanks, Ray. So a couple of themes came through from our panelists today from the community. I think being able to say yes, being able to offer wraparound care, support, sensitivity, all really important. And no travel, not making our patients travel in order to be treated for hepatitis C. So thanks very much to all of you. And now I'm going to pass everything back over to Sophia so she can moderate some questions and answers and open things up. Thank you.
Leslie, and thank you to all of the panelists who've joined us from community-based organisations and frontline service providers across Canada. It was really great to hear from you all and to hear a bit more about the reality of how some of the policies that maybe we perceive as being good are actually still not translating into improved care for folks. So I think this is something really important for us to think about, is that while moving the dial on these policies would be great, we need to ensure that they actually translate into a difference for people affected by hepatitis C. I think the questions that I can see in the Q&A box are probably mainly for Jason and Curtis to answer. So the first one is around who is covering the cost of the cartridge for Hep C testing, and I assume this is specifically in Australia. So maybe Jason, if you want to touch on what's happening right now and maybe what you're working on to try and actually get access to this increased across Australia.
So yeah, it's a very interesting question. So currently it's unfunded. So the costs of the cartridges are being paid for by pharmaceutical companies and or services themselves. Now, it's quite interesting. There's quite an incentive for some services to do this, because the way that the system's structured is that some services actually have a pathology budget that comes out of their clinic. So it's not all paid for by the federal government. And testing's not. So some services will receive funding from the state to do that testing. So for example, for a quantitative RNA test, it might be $180. For a qualitative RNA, it might be sort of $90. And look, I know the price varies in terms of the cartridge, but let's say, yeah, I think it's going to come out at about $60 for a fingerstick point of care RNA cartridge. So right now, that's the current scenario. What we're trying to do is there is an item number for hepatitis C RNA testing that is funded through the federal government. So anybody that has a Medicare card would be eligible to receive that testing for free with no out-of-pocket costs. But as I mentioned before, the issue is that that item number requires previous antibody testing to be done, which really makes no sense for a fingerstick point of care same visit treatment. So it defeats the point. And then also this issue around labs having to do the testing, but that means that has to be done in the four walls of the lab. That doesn't really help people who want testing done out in community services. So the issue is around ensuring that there's this quality assurance and quality control framework in place and this operator training framework in place. So we've been working together with the International Point of Care Testing Center at Flinders University, and the Kirby Institute has a pretty long history of doing point of care testing for chlamydia, gonorrhea, and trichomonas with the GeneXpert test in remote and rural Aboriginal communities, and has more recently been involved in a pretty massive scale up of COVID testing in remote and regional Aboriginal clinics. So Rebecca Guy's group has a sort of network of about 100 different sites across Australia doing fingerstick point of care testing for those diseases. So, and they may have made some headway around this application to the government to have what would be a clinic-based reimbursement, so that a clinic could actually get the reimbursement for the testing to cover the cost of the testing and the time for the nurses to do the testing, as compared to the lab-based reimbursement, which is currently in place. So we're just in the process of working with the Commonwealth to do some of the health economic analysis that would be required for that submission, and then pushing that forward. So I know it becomes even more complicated once you move to Canada, and each province is different in terms of the sort of reimbursement system, but I think that'll have to be sorted out at a sort of provincial, province by province level. I don't know if Curtis has any sort of thoughts around any of that, but yeah, it's going to be complex. But as Curtis said, I think you got to pick the easy wins and start slowly chipping away at it. The other problem is obviously the GeneXpert test doesn't have Health Canada approval yet, and it will need to have that before, but it is in process. I think it's in train. I know we've been pushing them hard to kind of get going, and I don't know, maybe Curtis and others have it well.
Just a couple, yeah, thanks for that, Jason. Just a couple of concrete thoughts. I think at a regulatory level and at a lab level, some reviewers look at point of care tests, whether it's serology or RNA, and they say, I don't know, it's not quite as sensitive as a blood draw PCR test. And I think, just as a reminder, the sensitivity for detecting hepatitis C in a blood draw that never happens is 0. So anything better than 0 is a step in the right direction. Second thing is the costs of the RNA testing, point of care RNA testing. I mean, let's just think back a couple of years when direct acting antivirals were $100,000 a pop. And we all said, this is, how can this possibly ever move forward? The drugs are too expensive. And lo and behold, the prices were adjusted to so that they became affordable to the payers. And so I think we need the same kind of big thinking action that we had when pharma got together with the Pan-Canadian Pricing Alliance and hammered out a deal to make these medications affordable, and that the cost was acceptable to the payers. I think the same thing needs to happen with point of care RNA testing. This is something that is like really, really needed. I'm certainly not a health economist, and so I don't really know how much it costs to manufacture these, but I suspect it's not quite as much as what is being charged. So if we could, scale up the access and scale down the price, I think that model would work just like it worked for direct acting antivirals.
And we have areas where we can save money to recoup the costs, right? Like we can save money in repeatedly antibody testing people, for example, because we see a lot of that when we look at the lab testing data in BC at the public health lab. We see repetitive antibody testing happening, despite the fact that we have a great province-wide lab result database where people can easily check what tests have been done previously, and the antibody status is not going to change once it's positive. And then we can also drop the genotype test, which in many places where it's not a bespoke in-house lab assay is the most expensive test. So, I mean, I'm not a health economist either, but it seems to me that it makes dollars and cents, right? Like you can cut costs in other areas and recoup that money that you then are able to spend on the point of care RNA testing. And I'm just thinking, like in BC, we have MSP billing codes for providing urine drug tests in a clinic, and that's for methadone and buprenorphine. So there's already a precedent for clinics being able to bill for the cost of an in-clinic point of care test. Why should we not get the same thing for Hep C? And I think a lot of OAT physicians might argue that some of those drug screens are maybe unnecessary and that they're used as a way to increase revenue in a lot of settings. So there's definitely other places that we could save money. I'm just going to go through some of the other questions. There was a quick one around elaborating on what the same day assay is measuring. So I guess we should clarify, we're talking about two different point of care tests for Hep C. One is a rapid antibody test, which is made by OraQuick. And the other test that we're referring to is a semi-rapid hepatitis C RNA test, which is the Cepheid Gene Expert one. And the question on here, I think, Jason, this is for you, is around whether if the genotype isn't required in Australia, does this mean that Zepatia, Harvoni, and 3D are effectively not being used?
Yes, there's absolutely zero. So, it's all GP and SOPL and SOPL Vox. But yeah, no, pretty much none of the other regimens are used. In fact, sofosbuvir was actually delisted as a medication to be used on its own by Gilead recently. So.
And then Curtis, I think this question was specifically for you around the point of care test that you were referring to. I think you made a comment earlier that point of care testing does need to be a priority in Canada. We have a lot of data to support using it. Are you referring to both point of care antibody and point of care RNA testing?
Yeah, so I apologize if I kind of muddled my my comments initially. The serology point of care tests are cheap. They're easy to use. It's a really good way of screening large groups of people, and so that should be available everywhere. And and that's not going to bust the bank. Ideally, I'd like to see Hep C RNA testing available. With I acknowledge that given the current costs, it's not something that we can do upfront. And Jason made the excellent point that it really depends on the prevalence of hepatitis C in the community that you're using these tests. If there's very small numbers, then doing a Hep C RNA test, an expensive Hep C RNA test in every one of those people is price prohibitive. If in some future time the running a Hep C RNA test was cheap and easy, just like it is for serology, then I'd say, well, let's just get right to the RNA testing. I think Jason has some comments to add.
I think that's a really important point, Curtis. And the one thing I want to emphasize is I think people And I think Curtis kind of alluded to it, when we have an easy Hep C RNA test, I think we do need to kind of step back. It's exciting, great to have this new technology, but we can't ignore the fact that this is like having a little mini laboratory on a desktop. These are PCR machines. It goes back to what Curtis said, is that they're highly sensitive and specific. That's because they're mini PCR machines. So, you're detecting virus. So sensitivity and specificity is certainly not an issue. If anything, if they're overly sensitive and they're detecting virus, below the limit of quantification, that's probably not clinically relevant. So that's something we need to educate people about, that when they do get a detectable but not quantifiable result, what does that actually mean and what do they do? But I just don't want to downplay the importance. This isn't just like, I'm going to go buy a machine and I'm going to start using it in my clinic. You really need to have the quality assurance. And when I say that, just so that we're sort of talking the same language, this is so that, there's tests that get sent that are blinded to the site that are known positive or negative or known high and low viral load, that the operator needs to do on an ongoing basis, A, to ensure that the machinery is working properly, and B, to make sure that the operator is doing the test properly. And that's something that in a lab, there's really strong, and Soph knows this because Soph's worked in a lab many years. These are things that the lab have down pat, really strong standard operating procedures around how you do the testing. It's in a controlled environment. We're taking this test, it's a PCR test, and we're doing it in an uncontrolled environment in a clinic. So the operator training is critical, and there needs to be a program in place for training up people in doing this. And we need to have a process in place to make sure that the sample testing is done in an appropriate way. And so I've learned a lot about this in the past year. I must say I didn't know a lot about quality assurance and quality control before the last year, but I've learned how important this is, and any point of care testing program is going to require sort of some systems in place to ensure operator training and appropriate quality assurance and quality control. So I think that's important, and that adds to the complexity of rolling this up and scaling it up. It's doable, but we just need to consider these things, and we can't just be sort of rolling out, scaling up point of care testing without having that stuff in place. I think it's just really important. I think someone said it's not cheap. That's the other thing. I think, again, I advocate for it, but if you look at the costs, for every dollar that you invest in machines and cartridges for point of care testing, you have to invest another dollar in training and quality assurance. That's sort of like a rule of thumb. So we just can't ignore that. So it's just pretty important.
I think it's a good idea for us to think about the fact that while this is complicated, we don't have to reinvent the wheel. There are already quality assurance programs in place across Canada for example, HIV point of care testing. In BC, we have a province-wide HIV point of care testing program, and it already has a really rigorous quality assurance program. And so there's infrastructure and training and all those things that exists that we could piggyback onto. And we also have a lot of the Cepheid machines in community settings across BC and in other provinces that aren't being used for Hep C right now. They're being used for other things, but the infrastructure exists. So you don't necessarily have to go out and buy a whole lot of new machines, right? So I just want to make sure that we balance the fact that while there is a lot of complexity here and it's not as simple as just buying a machine and putting it somewhere, that we're not reinventing the wheel. And I think Jennifer had something she wanted to add.
Yeah, so the only other thing I wanted to add about the POC RNA testing is also, I think we also need to recognize that for some people, getting a blood draw is not going to happen for various reasons. And so having access to that technology, I think it would be very beneficial, because I often wonder how many people don't come in and find out their status, because of having to have a blood draw. And here, even if we do have a positive DBST, we still have to do a blood draw. So yeah, there is that.
That's why I love the idea of dried blood spot cards so much. I mean, they're not perfect, And I completely agree with everything that Jason and Sophie have said. But we have a tendency in Canada to allow perfection to be the enemy of good. And, again, if we can do a dried blood spot card to confirm somebody's infection, that's better than no blood draw at all, because the person can't or isn't willing to provide a blood draw.
But we would still have a waiting period. I would say that.
Yeah, we had another question which was for actually around dry blood spot testing, and I think specifically for Ray. Ray, if you're there, did you want to turn your camera and your microphone back on? So the question is just around what you have found the most successful methods for post-test follow-up after dry blood spots with community members has been. I guess if anyone else has experience with dry blood spots, you're welcome to share your thoughts, but specifically, Ray, what are your thoughts on this?
When we went to dry blood spot, it was because it gave our communities time to process what might or might not come back. And we were really lucky when we started the process. I think for our communities, it is important because we have lots of people that come into our office and they won't take phlebotomy. Is that yes, I believe so. They don't want that at all. So even if we get a positive result, they're really reluctant to go that next step because of past history. And we've had people say that they've been drug users, and just looking at a needle sets them off. That's the last thing we want to do. So I don't think there's one answer or one size that will fit every person or every community. I think we need to be able to offer people a continuum, not just of care, but of testing as well.
Ray, I have one final question for you, because you spoke about this yesterday and I found it really interesting. You mentioned that in the community that you work in, there previously wasn't a word for goals, and that being able to talk about treatment meant that you had to talk about it in the present, because the idea of setting a goal for the future for an abstract time when treatment might be feasible was really difficult to talk about with your community. So did you want to touch on how you think that more rapid or potentially same day treatment starts could help to provide more culturally safe and person-centered care?
I don't know that rapid, like for some people, absolutely rapid testing will work for them. For others, it's not going to. And so the idea of goals was that we did things when it was seasonal, when it was appropriate to the season. And everybody knew that, I don't know where other people are. Here in Alberta, winter isn't supposed to start for another 24 or 25 days, the 21st of December. Well, I've had snow on my ground for quite some time, and we've already had temperatures that were somewhere south of comfortable. And so traditionally, we started being prepared for cold weather out here in Alberta, right? Whereas in other places, they prepared for rain. So that's what we were looking at when we're talking about goals, is that you prepare for what the season is likely to bring you, rather than you're in high school and you're preparing to go to college, that your goal is you preset the fact that you want your kids to complete high school and apply to a college before they're even out of grade 12 or to university. That those kind of goals, they were foreign to us, and so we didn't have words. We didn't have a word to describe sex, or to talk about it. You spend time together.
And so I guess from the perspective of somebody who is providing care to people in I guess what you're hoping is the most culturally safe way, but you're obviously constrained by policies and things like that. You've mentioned before you want a menu of options to be able to provide to people, right? Because one thing isn't going to work for everyone. I guess that's really what this discussion is about, right? Is saying that to meet people where they're at and provide person-centered care and culturally safe care, that we need to remove barriers, not create new ones.
And we need to know that we're providing culturally safe or appropriate care by their definition, not ours.
Yeah, and I think that's something that people touched on in the chat, was around peer engagement and community engagement. Yeah. So with that, I think, thank you so much for that, Ray. That was really interesting. Jennifer is going to, I think, pose some thoughts to the 4 member group panelists. So if you want to join us again, and I'll hand it over to Jennifer now.
Hi, thank you. Yes, and I'm very aware of the time, so I want to be respectful of everyone's time, but I wanted to just bring it back because we are AHC, and so of course we want to hear from our members again quickly what our next steps should be together in that community perspective. Action Hepatitis Canada is all about accountability from the community perspective to help meet our elimination goals by 2030 and what we can be doing to make that happen. So I'd like to hear just a 30-second version. I know that's ridiculous, but if I could ask you just a very quick version of what you, from your region and from the people that you're supporting, what you would like to see as a priority for Action Hepatitis Canada moving forward on this particular issue around testing and being able to start treatment right away in these barriers. So if it's okay, I'll start we'll just move east to west if that's okay. So we'll start with Luigi.
Hi. So yes, there were many comments from Jason and Curtis that I liked about, and also Sophia repeated, like, it's not a one-size-fits-all approach. In French, we say mur à mur. So it's like so that part is hard, I guess, for AHC. But when we're talking about in Quebec, like I said, we don't have community testing. So in other provinces, there might be other problems, but here that's the part we need to work on. And like Curtis said, there is 0% detection of like hepatitis C if we don't test the person. So that's an issue here, but it's different elsewhere. And I think AHC, like it's a really simple example, but like the graph you did, like I think comparative politics, analysis, and also like program evaluation, cost-effective analysis of different measures or testings or procedures, it does help us. Or also just like graphs or things that makes us aware of what is going on in other provinces, because it can help us convince around province, when we say like in this province they do that and they save money, or they have more treatment or whatever. So I guess it's yeah, maybe something that helps.
That's great. Thank you. Jennifer.
Hi, so I'm going to say what AHC could help us with is anything that gets us closer to doing, to being able to say yes to clients and to increase the speed, or increase the ease of which we could treat people. I think if we can say yes, to people in this area, then that also, frees us up to work on some of the other issues that clients may be experiencing, because really it's not all, it's very often is not just about Hep C care. It's about, wraparound care, and there are a lot of issues that are facing clients, the least of which isn't the least of which is homelessness and inadequate housing for people, and the poison drug supply. So I think, if AHC could, anything that helps us to be able to say yes and to actually, take care of this simple thing, so we can take care of some of the other things that are is equally important and priority for our clients.
I think that's a really good way of putting it. Thanks, Jennifer. Ray.
If AHC could help remove some of the hidden barriers, I guess, the unspoken, where you have to have stable housing before we're going to issue your medications. You have to be at this level, or you have to know where you're going to be tomorrow. That would be a huge one. If there's ways to help our clients get to distant specialists, and to have transportation or accommodations when they have to go out of town. And because many of our community members don't have transportation or don't have reliable transportation, and God loves some of them that have a license that I'm not sure where they got, but I would prefer to be pre-warned before we're going to be on the road so that I can stay off. That things like that, there's so many barriers that just jump in and start.
Yeah, thanks. I think that's one of the things that has stood out for me in this conversation is there are things at the federal level, there are things at the provincial territorial level. We have to get some testing manufacturers maybe on board so that we can even get those tests here. And then there are these unofficial policies, like I'm pretty sure it's not the province or the territory that's saying you have to have housing to get Hep C treatment. But you can get other treatment, but you can't get your Hep C treatment because of your housing situation. So there are definitely some unofficial policies that we have to take a look at as well. So that's great. Thanks. Bronte, last word.
Hey, less pressure. I think I echo a lot of what the other panelists have said, but similarly to Jennifer, things that can get us closer to being able to say yes to people and provide them with treatment and results as soon as we can. I think what that means in the Yukon is largely around pushing the territorial government to fund point of care testing, because especially when it comes to rural communities where we can't even do blood draws and the person's coming into Whitehorse, the chance of them getting testing is pretty minimal. And we know that harm reduction practices in those communities are limited too by resources. So you see spread. And then I think the other aspect would be encouraging territorial government again to fund and support other doctors to be able to provide treatment, because that is possible in the Yukon, but right now it hasn't been encouraged, and training hasn't been funded, and I don't think doctors are being supported in taking that on, which limits us to this specialist every 2 months. And really, I mean, same-day treatment would be amazing, but even being able to have someone see a doctor in a week versus 2 months would be incredible. So for us, those are some of the big barriers. And then, as Ray said, really looking at all these hidden barriers like housing and how a doctor observes someone's substance use, and the sort of decisions that are being made around an individual's capacity based on like one visit with a specialist that says, no, actually, I don't think that you could carry on forward with this treatment, and trying to find ways around that, because, you know, we know these clients well, we see them every day. And if those perspectives were taken into account, we might be able to support them in getting treatment.
Some really good points, a lot of really good points in a very short, condensed few sentences. So thank you, Bronte. So that concludes our virtual panel. I feel like we could just keep going all afternoon, but I think we're going to close it there officially, but I think the discussion is going to keep going. I think in a way we're stopping this discussion, but in a way we've just kicked it off. So I'm hoping that this can be an ongoing discussion, that we're going to hear from our members more and more about this. And I think that this topic is very engaging for our members. It's eliminating Hep C, I think, can feel a little bit abstract, but when we're talking about how can I say yes to the people that are in front of me, I think then it frames the conversation in a different way that is of a lot more interest to our members, and it's a more interesting conversation to have, quite frankly. So I want to thank all of our panelists for your time and your perspectives, and honestly the work that you're doing every day in your communities, and to Jason and Curtis as well for your expertise, and to Sophia and Leslie for joining me and being moderators today too. So thank you very much. And this recording, I should say, because I know I'm going to get emailed, the recording and the slides will all be up on the website very shortly. Okay, thanks so much. Have a good rest of your day.
Thanks, everyone. Bye.
Bye-bye.
Thank you.